join us. She works with the Hospital Council to give us a little bit of an update, and then we'll just kind of open up the floor from there. But I'm going to hand it over quite quickly to Dr. Russ Granach, who is joining us here. He is a doctor at the Hospice of the East Bay, and Cindy Hatton, who is part of our wonderful leadership team here at the Opportunity Task Force, was kind enough to connect us. Before I do that, I just want to mention you are here as part of the East Bay Leadership Council's Opportunity Task Force, and there is a wonderful leadership and planning team that helps us to put these meetings together, on which Cindy Hatton sits. So it's been wonderful to have her connection and take part in that. Jake Brumner is also part of that team, as well as Brian Dean. Really grateful to have them. And Elaine Schroth, who is part of the Visit Concord team, is part of that as well. So I just wanted to give a quick shout out to them and thank them for all of their work in helping to put today's meeting together and all of the future meetings of the Opportunity Task Force. And with that, I'm going to hand it over to Dr. Granach. Are you able to share your screen, sir?
I'm going to work on it.
Okay.
And also, Lindy, Bob's having trouble joining the meeting. So
okay.
He's encountering an error. So I'm going to go ahead and send him the link again.
Okay, do you see my first slide?
Yes, we do.
Okay, fabulous. Well, welcome everyone. I'm really honored and pleased to be here to talk to all of you. And I know there's a lot of stuff going on in the country currently, and it's distracting people, and you're all got all sorts of meetings, and I'm sure some things do conflict. So I appreciate the people who are able to attend. So anyhow, I was asked to just sort of talk a little bit about vaccine development and so forth, and then Dan Petticord is going to talk about distribution and all sorts of things along those lines. So anyhow, let's go ahead and get started. These were already mentioned. Please keep your microphone muted unless you're talking. Preferably, and I don't know if this is okay with the rest of the team, but if you have questions, just to put it in the chat box. It's easier that way, and then at the end. And I do expect you all to pay attention. I know it's really easy when you're looking at a computer screen rather than sitting in an audience, because you're here to learn something. So you can't learn if you don't pay attention. So hopefully you will. If you come out of this day with 3 new information that you have learned, then I would consider it to be a success, because that's the rule, 3 things. So anyhow, no disclaimers. Well, there are disclaimers. There's no outside people that are supporting this. This is all supported by Hospice of the East Bay. The information is all current understanding by what's out there, the specialists, the reputable organizations, but the information changes rapidly. And I actually had to change a couple of my slides this morning. So first of all, let's just talk a little bit about what a vaccine, what is the name? I like to start at the beginning because it gives you a foundation. So a vaccine, the first modern vaccine was smallpox in 1796, Dr. Jenner. You probably have all heard of him, and he infected people with cowpox, and there was a cross reactivity with smallpox, and it would give people immunity. Interestingly, the scientists don't know which strain of vaccinia, how he got it, because it happened to be exactly the right one of all of them that are out there. But what does the word actually vaccine mean? So cowpox is vaccinia, so it kind of seems obvious, but vax means cow. And "ine" is a feminine plural in modern Latin, so vaccine is the word. So basically, vaccine means cows. So anyhow, just kind of an interesting tidbit. There were some pre-modern vaccines that were out there. In China, we know in the 1500s, they were able to take smallpox, basically material that had smallpox in it, dry it out, and have people inhale it, and they found that that helped prevent smallpox. It's still, because it was a live virus, some people did get sick from it and died, but the mortality was significantly lower than the disease itself. So vaccines have been around for a while, and you're going to hear a bunch of terms. DNA is our genetic code. RNA takes the code and applies it. And to give you an analogy, I have on my computer a program with all of my recipes. So think of the computer as the nucleus with the DNA in it. I want to make one recipe, I pick it out, I print it up, I bring it to the kitchen. That's the messenger RNA, is taking that recipe from my computer basically to the kitchen so it can be made. And then as soon as the recipe is done, that piece of paper gets tossed. So that's what messenger RNA is. Then we have two different types of lymphocytes, T cells and B cells. The T cells do a lot of the work and the manipulation. They're killer cells. They read information about what they're trying to fight. The B cells basically produce antibodies. It's a T cell deficit that's a problem in HIV disease. It's an integral part of our immune system. Antigens are anything that stimulates your immune system, generally a protein. We've heard the term spike protein, M protein, particular to this virus. APCs are antigen presenting cells. They basically will engulf the antigen and they present it in such a way that it links onto the T cell and T cell can read it and start the whole process of the immune system. And the antibodies are things that stick onto the antigen and basically block the virus. So that kind of works two ways. If we look at this picture here, and we see this is what the virus looks like, and it's called coronavirus because it looks like a crown, and you got these spike proteins, and it kind of almost looks like a key. So this is made up of three proteins that are interwoven. It's a very complex three-dimensional design, and it fits into this receptor on the cell, like a key into a door lock, and you turn it and you open up the door. You need the right key. So think of the antibodies does two things. One is it gums up the key. It's like putting silly putty or clay right onto the key itself, onto the protein, so it can't lock in. The other is it identifies, it's like a tag. So the killer cells can then identify this as something that needs to be destroyed and will destroy the virus. So normally the way a virus works is it has some sort of receptor attaches to the cell. It gets inside your cell. It breaks open whatever's inside, which is RNA in this case. And cold viruses, usually it's DNA, comes out. It somehow goes in and instructs your cell how to make the proteins, right? This is the recipe, comes out, tells you how to make the dish. You make all the different pieces, you measure out your cayenne pepper and your butter and so forth. You put it all together, you get this beautiful dish, which is a virus. And then bingo, it goes back out into the system. Now, often the cell will get filled with thousands and thousands of these viruses, and then will just burst open and it'll all be released into the bloodstream. So that's how viruses cause their infection. Now, we're talking about today about a vaccine that came out incredibly fast. If you look at some of these other major vaccines, on the average, it was over 10 years. Chickenpox took a long time. Even if we eliminate that, it's 8.5 years average time for vaccine development. We did this one in less than a year. I'll explain some of that why in a moment. And then, of course, why do we vaccinate people? Well, we want to control the pandemic. I mean, to me, it's pretty straightforward. The quickest path is vaccine. We can get a lot more people immune very quick by vaccinating them. And of course, we don't have the of natural immunity from people getting sick and becoming immune. The estimate is about 70% of the population needs to be immune for that concept of herd immunity. I'll go into that in a little bit more detail. And we do know that COVID-19 is the leading cause of death currently in the United States, and we can avoid that by vaccinating people rather than letting them get sick on their own. And if we did let people get sick on their own, if we didn't have this technology, if this was 50 years ago or longer, and we had to wait until 70% of the population got sick, every one of us would know at least one or two people directly who died from COVID, because the death rate is about 1%. Most people have at least a 1 to 200 person circle of people they know well. So it's not like you heard of it, someone at work's, a cousin died, it would be someone you know and probably socialized and so forth. And we just don't want that to happen. Now, there's a certain amount of math in figuring some of these things out. So there's this concept called the R naught, and that basically means how many people can one person infect. Now, obviously you can infect thousands if you expose yourself, but on the average, if you were with a few people, how many people are most likely to get infected? And the thought is that with this virus, it's somewhere around 3. We don't know exactly, but that seems to be right. So now let's imagine that we can take these, if we can lower that down to less than 1, the R naught less than 1, then the disease will start going away, because if you can infect less than one person, eventually you have 1 million people, you infect 900,000, they infect 800,000, eventually you get down to 0. So we want to get that to less than 1. So that means you have to get 2 out of those 3 people need to be immune. So if you're with 3 people that you're going to infect, if 2 of them had the vaccine and are immune, you can only infect 1. So we need to exceed that 2/3 immunity in the population. And that's what the concept of herd immunity is. You don't have to immunize everyone, because eventually the disease will go away. So let's assume we have 10% of people are naturally immune from getting sick. And we need 60% of the rest of the population to be immune via a vaccine. If you have a vaccine that's 95% effective, you need to immunize 63% of the people to get 60% immunity. So that's the basic math with this. I won't go into how the effectiveness is calculated because we are time limited, but I'm going to quickly run through different vaccine types and then focus on the ones that we're talking about today. So there's inactivated virus vaccines. The virus has to be grown in a lab. It's very technically difficult. You need to have a level 3 containment so the virus doesn't spread. You inactivate the virus and your body then produces antibodies to the various parts. And we're seeing this being developed in countries that don't have the technologies that we have currently. Live attenuated vaccines. This is commonly what we use as one of the forms of the flu vaccine, particularly the ones that kids get, and they get it as a nasal spray. And basically it's just a weakened virus. It causes basically a low-grade infection. It should be subclinical, meaning you don't get any symptoms from it. But you get a very good immune response because you get immunity to all different parts of the virus, not just the spike protein. And it could also be given intranasally. And the really good thing about that is you develop antibodies locally on near nasal passages. So if you were to be exposed to a virus, it wouldn't even get into your blood system. It would be killed off before it reaches internally. But there's nothing that's on the horizon of this type. There's ones where you make the protein, like the spike protein and so forth, but you have to grow it in cell cultures, a long, laborious process. And there's one study in phase 2. Now, there may be ones moving along. It's hard to keep track. There's over 175 different vaccines in development, but that was fairly recent data. Viral vector vaccines, this is what the AstraZeneca is. And basically you take another virus, and I'll go into more details about the AstraZeneca one, and you modify that virus, and you infect the person with it basically by giving them a shot, and then they develop immunity to what that other virus will encode. And there's DNA vaccines where you basically produce DNA, and then that makes the messenger RNA, which makes the spike protein. Very, very easy to make. However, it's really hard to get the cells to accept the DNA. Viral vector can do that successfully because the virus is the media to get the DNA into the nucleus. So these really are not terribly promising, but we didn't think messenger RNA was promising many years ago. So the RNA vaccines, they're the only two that currently have the emergency use authorization. The messenger RNA gets into the host cell, and it helps that recipe gets in there, and you make spike protein. And you make a whole buffet of it. The messenger RNA does not get into the nucleus of the cell. It does not alter your genome or interact with your DNA in any way whatsoever. And it's a new technology, and it can be made entirely in the lab. You don't need any type of cell cultures. You don't need to grow anything. You don't need any level 3 containment. There's no virus involved, period. So all you need is that information to how to make that protein. So the vaccines that we currently have are these two from Pfizer and from Moderna. Those are the official names. I don't know how they came up with them, but that's what they are. They're pretty comparable. They both make the same spike protein. They have a similar efficacy, 94, 95%. The numbers, we're talking about tens of thousands of people in the study, but the number of people who got sick, and the Pfizer is only 162 in the placebo group. So, you can imagine one person either way is going to change the percent, but they're pretty much the same. They're not interchangeable because we've never studied that. In theory, you probably could get one and then the other one, but we don't know. We don't know if it's going to work right or not. So we're sticking with one vaccine per person, one type of vaccine per person, which is 2 doses. We don't know how long the immunity will last. We do know that it's better than getting sick. And when you get sick with a disease, you will develop immunity. You'll develop a more robust immunity if you get the vaccine. Part of the technology is to make that protein really delectable to those T cells. So that way they can develop a lot of antibodies. We may need a booster in a year or 2 years, who knows? We'll kind of learn more in time with population studies, maybe some antibody testing, but antibodies don't necessarily tell you how good your immunity is. There's a whole host of antibiotics. They're not all protective. And you also have what's called memory in your T cells and B cells so that you can actually, when they get stimulated by an antigen, they can immediately produce it. Just think of a factory that's closed down because you don't need the product that's being made. And you just turn on the lights, hit the on button, and bingo, you got antibodies. You don't have to learn the whole process and build a whole new factory. So in the messenger RNA vaccines, they're both about 95% effective. Now that is in preventing symptomatic COVID-19. We did not study to see whether people get asymptomatic disease. It's still possible that people could get infected with the virus. The virus is killed off before it causes any type of symptoms in the person, but it's possible that you might be shedding virus for a period of time. We just don't know. Well, you don't know if it decreases asymptomatic disease at all. Now, the thing is that people who did get sick with the that took the vaccine, so 8 people out of about 22,000 in the Pfizer, they had mild disease. So we know that there's probably also some partial immunity. And we do know that from the data, there's not robust data, but there is a suggestion that after 10 days after the first shot, you're already at about 89% effectiveness and immunity. The numbers aren't high enough to say that for sure, but they look pretty good. And then when other vaccines have been out and been produced, the really serious side effects pretty much always occurred during the phase 3 studies, usually within 6 weeks. So there was really nothing there. The side effects of this, even when the category of serious means the number of % of people who've gotten it, they've all been relatively mild type of things, more like feeling like you're ill. We'll talk about that more. So, oh, here, I do actually have this slide about Pfizer. So 43,000 volunteers, they checked 7 days after the second shot, make sure no one was infected, then they started counting numbers. 170 cases totally after 28, after the shots in that period of time, 162 in the placebo group, 8 in the immunized group. So that means you can infer that of the immunized group, 162 should have gotten sick, but only 8 did, which then you do the math, you get a 95% efficacy, and that's how they figure out those numbers. Now, if we compare the 2 different vaccines, there's some minor differences. The dose is higher in the Moderna. You have to give it 28 days apart as opposed to 21. We're not exactly sure how they came up with these dates. The Pfizer comes in the 5-dose vial, but if you have a 0 dead space syringe, you can actually get 6 shots out of it. You got to store the Pfizer in a very cold freezer. They actually put a temperature monitoring device on the storage containers. And that's what the cold chain is, that every time it passes like a link of a chain from one person to another, one company to another, it has to be monitored. There's actually, my understanding, a button that you press on the device and it sends the information of the temperature monitoring and the change of ownership to the manufacturer. Moderna can be stored in any freezer that's a medical freezer, basically guaranteed temperatures. It's stable for 30 days in the fridge. The Pfizer, once you defrost it, you get for 5 days. Moderna's for 18 and older because that's the group they studied. Pfizer studied 16. And if you place an order, you need to order at least 975 Pfizer doses. Why it isn't 1,000, I don't know, but that's what it is. And now if we look at the AstraZeneca, that's a viral vector. It uses a chimpanzee cold virus, adenovirus, that has been altered that the DNA includes the information for producing messenger RNA to produce the spike protein. It's about 70% effective. It actually is 2 shots. I'm not sure why I have that bullet in there. But the 70% effectiveness, interestingly, it broke out into 2 groups. One group accidentally got a lower dose in the first injection, and they seem to have a 90% effectiveness. The thought is that maybe the first dose primes the immune system better at a lower dose. There's also a thought that maybe people develop some immunity to the virus itself and the vector, which is one reason you use animal viruses instead of human viruses, because if you use human viruses, a lot of people are immune and they wouldn't even get into the cells. So there are some questions about how the studies were done. So that's kind of holding up its approval by the FDA. And it does cause fatigue, headache, fever, similar type of symptoms. There was one case of transverse myelitis, which is inflammation of the spinal cord at a certain level. They're not sure if it's directly related or not, but it was only 1 out of tens of thousands. There was one other case, but that was clearly related to multiple sclerosis. So who should get vaccinated? Everyone. Even if you're immunocompromised, there is no virus in the vaccine. You cannot get sick from getting this vaccine. Prior infection is not a contraindication. As I mentioned, you'll actually get a better response, and this will boost your immunity. People who have been infected are advised to get it, but usually advised to wait because you probably have pretty good immunity for 3 months. There's no rush. Let other people get the vaccine. If you did get convalescent plasma, then you should not get the vaccine because it may interfere with the efficacy of the vaccine. If you're pregnant, probably should get the vaccine. Obviously, you need to check with your physician first, but the American College of Obstetrics and Gynecology generally recommends it. There's a CDC and an NIH statement, both advocating that, and if appropriate and approved by your physician and you're pregnant, even though it wasn't studied, you should get it. There were about 30 women who got pregnant during the study, had no adverse outcomes from it. And one thing we do know that if you are pregnant and you get sick with COVID, you're more likely to have a more severe disease. So it's felt that that's probably a good idea. I'm just going to answer here a few questions that I have been asked a lot, just to preempt it. Which vaccine should you take? Whichever one is available. They're pretty much equivalent. What happens to the messenger RNA? Is there any long-term issue? Is it going to change your genetics? One scientist from UCSF, I like the way he put it. He says, people always worried it's going to change their genes. They're going to get multiple sclerosis. They're going to get, autism, this and that. And he says, why doesn't anyone ever worry that they're going to turn into Spider-Man? So anyhow, I think that would be a lot better. So anyhow, your body breaks it down. It's like that recipe. When you're done, you toss it. It's not in your system, and probably hours to days, it's going to be out of your system completely. And then the new strain that we've all heard about, will the vaccine work? Yes, the vaccine will work. The structure is similar enough. It's not going to make a difference. We think it's more contagious. We don't know for sure because it affects younger people, and younger people are not as good about masking and social distancing, and they do a lot of stupid things. So, and I can say that from my own family members, the next generation. If you had another vaccine, you got to wait. So if you had your, your shingles vaccine or flu vaccine, you got to wait 14 days before you get this one. And then what happens after you get your injection? Can you stop wearing a mask? No, you can't. You still got to wear a mask. As I mentioned, we don't know if you develop an asymptomatic infection, whether you could be contagious. Right now, the recommendations do everything exactly the same as you would do as if you were not vaccinated. Even if you're exposed, you need to quarantine and so forth. And more information will come out on that later. And then what if you miss the second dose? Not a big deal. You get it when you can. You probably have very good immunity. And as I mentioned, overall, let's see, the numbers have changed. When I first put this slide up, they were saying 70%, but then it came out as 89% after 10 days. It's about 50% before 10 days. And then are there any plans to give one injection? As far as I know, nowhere in the United States, they plan on doing the one injection and then waiting to make sure everyone gets one shot first, like they're planning on doing in several other countries around the world. Presumably, if production is going really fast, it really wouldn't make a difference. You'd still get your second shot, but currently when you get your shot, they're saving the second one for you. They're not giving it to anyone else. And what type of proof do you get? Well, you're going to get a little card. It's going to be put into a database. And here, if you work for a healthcare organization, let HR know about them and send them a copy of your card. And this is the type of card that you're going to get. So that's front and back. And you're going to get a handout. This is the official CDC. The county gives out a lovely handout with links to all sorts of other resources. It's several pages long. And it'll explain to you the things that you need to look at. There is this software that you can get and install on your phone called vSafe. And what it'll do is you put in the date of your shot, remind you of your second one, and every day if you've had any side effects. This is one way that we can use to monitor side effects of the medication. So I recommend that you do sign up for that. And then lastly, side effects. So basically, the side effects are pretty much the same in both vaccines. They're what we call reactogenic, meaning it's a reaction to getting a vaccine. It's not something caused by the substance of the vaccine. So basically, you're developing an immune response. The immune response is first going to develop in your arm where you get the shot. So you get swelling and pain. It's a good thing. The proteins that get spilled out into your bloodstream to develop to help the T cells and your APCs and so forth can cause sort of like a little serum sickness is kind of concept. It's very mild. Basically, it may give you some malaise and symptoms like you're sick with a cold or a flu. Tends to happen more likely in younger people after the second dose. and they're just general vague symptoms. Usually at the worst, they last a couple of days. Most people will, if they have symptoms, will still be able to work and function otherwise perfectly normally. And of course, we're going to learn more with time. Anaphylaxis, that was a big thing because it made the news. There are 2 cases that were widely publicized. Both people had histories of bad allergies. Both people had EpiPens on themselves and were able to give themselves a shot. We found with this, and that when they were looking at the doses over a 9-day period of time, or 10-day period of time rather, there was about 11 per million doses of people who developed anaphylaxis. The majority of people had known previous serious allergies. So they recommend monitoring people at least 15 minutes. Almost all of them occurred within 15 minutes. And for anyone with a history of allergies, a 30-minute monitoring. So that's it from me. And I will hand over the baton to Daniel. Thank you.
Thank you so much. That was incredibly thorough. I feel like you gave me and Kristen a run for our money in trying to cover a lot in a short period of time. So for anyone, we will be recording this and posting it for members and sending out some information about that. But without any ado, I'm going to hand it right over to Dan Petticord, who is a member of our Opportunity Task Force, joins us a lot, and is really often able to keep us informed about what's going on at Contra Costa County in the Public Health Department.
So let's see if I can figure out how to share my screen.
Well, we're seeing a beautiful beach scene at the moment, so that's a good sign.
Well, yeah, sorry about that. Here, let me.
No.
Hang on.
We know it's not you, Daniel, unless you cut off your pigtail.
Hang on just a sec. I'll be right back. I'm going to get some help.
Not a problem, but while he's gone, I will say there's a question here that might be worth taking it in the meantime, Russ.
So I need to
find
my
back.
presentation here. I had it open. So that's it. Share it.
Well, I think you might be seeing it, Dan.
If you're sharing your desktop, maybe just maximize the page.
Here.
Yeah.
Sorry for the technical difficulties, folks.
Move this over, and then you can maximize that right there.
Okay, are you seeing my screen?
Yes, we are.
Okay, I'm going to skip through the first few of these slides because Russ, you did a great job covering a lot of this. And as I listened to you, I was thinking, I sure in the heck wish I'd have had you as my immunization or my immunology instructor in college. You did a great job. So these slides are here, but we can go back to them and you can refer to them later. I can share these slides with all of you. But Russ did an absolutely great job of covering this part of the material. If anyone's interested, this is the actual ingredients in the vaccine itself. So let me start with vaccine safety. There are multiple ways in which the vaccine is reviewed for safety before it comes to market. Russ talked a little bit about that. The FDA and the Advisory Committee on Immunization Practices reviews the safety data from what are called the various phases of human trials of the vaccine. And long story short, they go through phase 1, 2, and 3, and it really just is more and more people added to, and different types of people, meaning, for example, in some vaccine safety things, they might add pregnant women into the safety trials to make sure it's safe for pregnant women. In this case, they did not do that. But the important thing to note here is that for Californians, you have 3 levels of safety before it came to market. The ACIP reviews the data in depth from the manufacturers, and these are a group of scientists and health professionals. They then make a recommendation to the Food and Drug Administration. The Food and Drug Administration does their own review. And then here on the West Coast, we had the benefit of a multi-state expert panel from, I believe, Oregon, Washington, California, and Nevada that reviewed all of that same safety data and again affirmed that from their perspective, this vaccine was safe to come to market. So after the vaccine is out and people start receiving the vaccine, we have 4 different ways of ongoing monitoring of vaccine safety. This vaccine adverse event reporting system has been around for years. It's the way that if I have an adverse reaction and my healthcare provider knows about it, they'll work with me to enter that data into an electronic database that goes to the CDC, to the state, to the local health department. vSafe, which is the application that Russ just showed, is a new type of smartphone-based technology. We have a few of our staff here that are patient-facing that have received the vaccine, and they've told me that they get a little message. So this is something that you sign up for after you get vaccine. It's totally voluntary, but they get daily messages to report back, you know, are you having any adverse reactions? Do you have these kinds of symptoms? And so again, this information gets loaded up to the CDC, back out to the state, back out to us locally. There's the vaccine safety data link. You can kind of just read a little bit about what that is there. And then there's the Clinical Immunization Safety Assessment Project, which is what clinicians use when they have a question about a specific patient and whether or not they're eligible for the vaccine. Going back up here to the VSD link, I just want to note that one of the 9 national sites that studies vaccines, including the COVID, is our own local Kaiser out of Oakland. So that's a little kudo to us here in the Bay Area. Last week on January 6th, there were 2 really important articles published, one in Morbidity and Weekly Report that comes from the CDC. That was a summary of the nearly 2 million doses that had been administered across the United States as of December 23rd. Obviously, there are millions more that have been administered since then. And I just put a little summary here, which really the bottom line is it looks like it's really, really safe. And then the Moderna phase 3 trial information was published in the New England Journal of Medicine. I didn't summarize that, but I think as Russ encapsulated, it also appears to be pretty darn safe. And as safe as you might expect to see with your normal flu vaccine that you get every year. So now what I think everyone is probably chomping at the bit to know a little bit more about is our vaccine rollout strategy. The best single source for this information are the 2 web links that I've attached here. For the general public, it's the top link. For healthcare providers, it's the bottom link. Please know that what I'm about to share with you is very fluid. And I think, you know, I had to smile when Russ mentioned that he'd had to update his slide deck a time or 2. I'm now on my 4th iteration of this simply because things change literally day to day. And you may have heard an announcement that came from the federal government, from the Trump administration, of wanting to push vaccine out to folks 65 and older immediately. I'll talk a little bit about why that's not a good idea immediately, but these are how frequently things are changing, literally every day. So this is just a snapshot of the general concept of the phases. The federal government actually looks at this as 3 phases. Here in California, we boiled this down to 2 phases and got very complicated in phase 1. We are still in phase 1A as we speak. We're finishing that up. And then effective actually today or last night, perhaps, Contra Costa Health Services announced that it will begin vaccinating folks 75 and older in phase 1B, but not 65 and older yet, not other essential workers yet. We want to get through the 75 and older before we jump into the rest of phase 1B. I'll just make a couple general comments. We have, to this point in time, received about 40 to 45,000 doses of vaccine into the county. That does not account for a separate pharmacy program that I'll talk about in a moment, and the separate doses that are being sent to hospitals just to vaccinate their healthcare workforce. In the first few weeks of this, which goes back to literally just a couple days before Christmas, when the first few doses of vaccines started coming in, and then really through the end of December, the county itself, our public health department, was in the business of receiving virtually all of the vaccine that came in. I mean, literally every single dose that came into the county came into us, and then we would redistribute back to the hospitals and to this long-term care pharmacy program that I'll mention in a moment. That is now transitioned where the hospitals and the long-term care pharmacy program are receiving doses directly. So literally as of yesterday, this is where we are. We're still finishing up tier 1A, phase 1A, tier 1. And going into tier 2, going into tier 3 as we speak, literally. And then just again, as of yesterday, are now expanding eligibility to the folks that are 75 and older. The next couple slides that I show you just should be taken as just general information, but it's to help illustrate the size of this lift through just simply these 3 tiers in phase 1A. So we have approximately 70,000 healthcare workers in our county. And you can see how this is generally divided up. I think CCRMC is probably included in the local health department because I do not have 6,000 employees who work for me. But when you look at how many report through up through Anna Roth, it's probably about 6,000. So the idea here is that we actually need to work through this sector, or the vast majority of this sector, before we move on aggressively to the other tiers. And the reason for that, I think, is painfully obvious, which is our hospitals are nearly at capacity. Our ICU beds are in very short supply. And the real big issue there with short supply is worse than just available beds. It's available staff to staff those beds. So most of our hospitals can go a little bit above what you'll see in the public as the number of ICU beds they have. They're actually required to have a plan to surge up to about 120, even 130% of their ICU capacity if they have staff. So staffing is a critical issue right now, which means we need to do everything we can to keep our frontline healthcare workforce safe and out of harm's way of COVID-19, which is why they're really in the very top tier of being vaccinated. I would estimate at this point that we have somewhere close to half of this population currently vaccinated as we speak, and a few systems have moved ahead with second doses. Not everybody, but a few of our systems. This is a snapshot of this same slide here, but by facility type. And you can just see a ballpark estimate. We have over 2,100 of these facilities across our county that we're working with partners and scrambling to try to vaccinate as quickly as we can. Just as an example, there are about 11,000 in-home healthcare workers in our county, and the county itself has elected to go ahead and vaccinate that part of our workforce out there. Other hospital systems obviously are vaccinating their workforce. I provide $1 for every physical therapist, occupational therapist, dentist, veterinarian, and every other type of clinician out there that is not affiliated with a large system. I'd be a multimillionaire by now because I'm literally inundated with requests from those types of practitioners about where do I go to get vaccinated, and where they go is the county, or we have a new emerging partnership with John Muir that's helping to campus a lot of that need as well. So once we move on to phase 1B, which we're just starting to now with the age 75 and older, this group as a whole here, and just tier phase 1B across these 2 tiers is roughly 300,000 people, a little bit over, in fact. And so it's a Herculean lift based on the amount of throughput that we have right now. I would describe this as we're trying to fill up a lake with a garden hose. It is sort of that sense of urgency and demand for this vaccine that we've yet to construct the throughput to move vaccine really with great expedition. That will get better as every week goes by, for sure, as we bring on more partners. So while you've heard that the critical shortage is available vaccine, and it absolutely is, the other critical shortage is the throughput, the amount of bodies that can put vaccines into arms, which again is we're building that plane as we're flying it. Moving ahead just a little bit, and this is more sort of into the spring, where folks 50 and older would be eligible. Individuals really 16 to 64 would be eligible with underlying health conditions, which is just between these groups up to this point, we're looking at 70 to 80% of the entire county population. So that's a lot of people. So which really means by the time we enter what we're calling phase 2, which is everybody out there 16 and older. We've then vaccinated the vast majority of the public healthcare workers, folks at high risk that, for example, that live in nursing homes and things like that. So that, again, by the time we reach phase 2, hopefully by early summer, midsummer, and keep your fingers crossed, we'll be well along our way to herd immunity, as Russ mentioned a moment ago. This next slide just is a snapshot of the age distribution in the county. As you can see, it's a sizable lift. If we're really talking about 50 and over, which are over 420,000 persons in our county. And the reason I selected 50 and over is that's where the arc of serious illness really begins to go up. And it's climbed steeply with every 5 years of age. And so, you know, by the time you're 80, you're exponentially more at risk than you are at 50. And you are exponentially more at risk at 50 than you are at the age of 15 or 20, for example. The reason it's age 16 and above is that the vaccines have only been studied in the age cohorts and above. So during the clinical trials, persons under the age of 16 or 18, and Russ can remind me whether it was Moderna that's 18 and above and Pfizer that's 16 and above, folks under those ages were not studied. So technically, they're not eligible for the vaccine until we know a little bit more about vaccine safety in that age cohort. So ideally, each and every one of us would be able to go to our own healthcare provider to receive the COVID vaccine. And that's the plane that we're building as we're flying it. You might have some obvious questions. This is, well, why is this any different at all than your normal influenza vaccine? And that really has to do with a couple of things. One is that the vaccine was manufactured in a really quick period of time and has very special handling requirements. And I won't go into the details of what those are, but they are, you know, they are volumes and volumes thick of details around handling. And so because of that, it has yet to be widely available to every provider out there in the world. But that's going to change hopefully fairly quickly. So in phase 1A, we're leveraging, obviously, Contra Costa Health System, the Public Health Division is helping lead that effort. All of our hospitals are vaccinating their healthcare workforce, and some of the hospitals, like Kaiser's and John Muir, for example, and Sutter, are beginning to think about moving into phase 1B, which is the 75 and older population, and even offering vaccines to the general public who meet that age group, not necessarily exclusively their members, which is a really, really important breakthrough that's literally just less than 48 hours old. The federal pharmacy program that I mentioned is literally a federal program that for weeks we've been scrambling to try to get more information about. But the bottom line is this is the federal strategy for getting vaccine into the arms of residents in long-term care facilities, of assisted living facilities, SNFs, board and care facilities, as well as the staff that work there. And then other partners like Lifelong and La Clinica, the FQHCs, and other community partners will be coming online in the next few weeks to a month or so. So it's going to get better. There is light at the end of the tunnel, but it's, you know, we're all really frustrated right now because there is some vaccine here, a little bit still in the freezer, and everybody wants it. So I just wanted to show you this slide to, I guess, illuminate a little bit about our partnerships. And this is not all inclusive, but it mentions some of the real key partners. Obviously, all the hospitals, the federal pharmacy program with Walgreens and CVS that's getting out there. And the reason I'm looking around is I had, so just as an example, there are 77 skilled nursing and assisted living facilities in our county with 30 or more residents in there. So there's way more facilities out there, but these are the mid-sized to larger facilities. 40 have already completed their first dose of vaccinations, and by the end of next week, all of those will have been completed either through this program or the county in partnership with John Muir and a few others is also tackling a number of the facilities that did not sign up for this federal pharmacy program. John Muir has been an amazing partner. They're within their bandwidth helping us with residential care facilities, and have also offered to be a site in addition to the county's vaccine clinic sites to vaccinate folks like the standalone doctor's offices, dentist offices, veterinarians, et cetera, OTs and PTs. And then what's also very important for you to know is that at the present time, and probably for the next few weeks, I would suspect, we're giving vaccine through what we call closed pods, which is just a fancy way of saying, come into our clinic, eligibility only, sign up for an appointment. We'll tell you when the appointment is, and then we'll vaccinate you. So we're not yet to the point where we're doing these large mass drive-through clinics at stadiums and things like that you've heard about in some counties and in some places across the nation. I think what's important for those of you that are here to note about Contra Costa Health Services is that it is uniquely our obligation to make sure that phase 1A is completed before we boldly charge into the next phases, leaving our healthcare workforce, our folks in congregate settings, and that workforce still at risk for COVID exposure. So, we're going to be another few weeks before we really put that beast to rest, and then can, with confidence, move on to the other phases. A little bit about what to look for ahead, and it's really messy right now. I'll admit that. The special handling things and the inability to have a large number of community providers already eligible to receive vaccine is really frustrating. Just today, a new statewide system called CalVax went online that should look very familiar to providers who normally order things like vaccine for children and adult vaccine series. So it's a much more user-friendly system, thank God. And so with that and with our continued outreach, we hope to sign up more and more providers for direct vaccine shipment. So it won't have to pass through our hands anymore. So again, we're building that plane as we're flying it. But literally as of late last week, I think there were only 25 or 30 providers, which includes the hospitals, includes us, that had signed up for direct vaccine distribution. And there were a few in there that simply aren't eligible. So, probably 20 or so providers at this point are even eligible for direct vaccine shipment. And just, I think I'll close by saying that it's important, I think, to note that this vaccine has come to market in far less than half the time it would normally take a vaccine. It still has some very special handling requirements associated with it. We were lucky in that we were one of the counties that got out ahead of the need to purchase these ultra cold pharmacy grade freezers that can hold the Pfizer vaccine at about minus 70 degrees, 80 degrees centigrade. It's very, very cold. So we acquired several of those, and because of that, we've gotten a little more of the Pfizer vaccine in our county than the Moderna vaccine. We've also set up some partnerships with some pharmaceutical research companies that happen to be located in our county that have these ultra cold freezers that we're storing some of the regional vaccine there for other counties as well. And I'll just end by asking folks to be patient over the next several weeks to months as this rolls forward. And I think, as Russ mentioned, it's extremely important that we all continue to mask, social distance, and avoid gatherings, even after we're vaccinated. We are a ways out of the woods on this, but there is light at the end of the tunnel. And it would be my hope that we can all enjoy some sense of return to normalcy by about midsummer. This won't be completely in our rear view mirror by then, but we should be in a much, much better place by then. We are literally right now as we speak at the peak of our very worst moment, in the sense that the surge of cases thanks to Christmas is we're smack in the middle of that. And on top of that, we're now beginning to see the surge from New Year's. So it'll take about another 2 to 4 weeks to work through these two surges until we can sort of say, okay, now our hospitalizations are predictably going to be on the decline. Our ICU beds will also then be freed up. The rate of increase in cases has leveled off a little bit, which is a very good sign to all of us in the health delivery part of this challenge. because it can't get much worse before the system really is at a critical failure point. But keep your fingers crossed. We're at about the worst moment right now for the next 5 to 10 days. And if it continues to level off and starts to go down, we'll be able to say, okay, we think the worst of the worst in terms of the surge in caseload is behind us. That's a big if, but it will still be extremely important that we continue to roll out vaccine with increased volume week by week. So, as I mentioned, we've had about 40,000 doses into the county. At large, we've administered well over 30,000 of those doses, have appointments for all of the rest already lined up. And statewide, we've heard that next week, the allocation to the state will be less than 500,000 doses. It should be closer to 1.5 million to really meet the state and national goals, which are for California, roughly 2 million doses a week. And we're far from that at this point in time. And for us, we're trying to reach somewhere between 20 to 30,000 doses a week on the go forward week by week as we build towards there. There are a few of my colleagues who are somewhat confident that we'll be at 30,000 doses a week being administered across the county by the end of the month. I think it's a little optimistic, but I think it's important to push us to that point. That's all that I have. And if there's any time for questions, I can take a question or two.
Thank you, both of you. And we have a lot of questions in the chat, so I don't think we'd be able to get to all of them, even if we did have an extra 30 minutes or so. But I want to thank you both again for these great presentations. And really quickly, we did ask Rebecca Rosen, who is with the Hospital Council, to join us as well. So Rebecca, I just wanted to give you a moment if there was anything you wanted to add or any insight you might provide into kind of what our hospitals are seeing. To those of you who did put questions in the chat, thank you. Russ and Dan, if you have a moment to maybe go into the chat and answer a few, if we have a moment before we end, we'll certainly try to get to them.
Yeah, I'm just going to pick a few. Yes, education is phase B tier 1. So we're not quite there yet. We're just now into phase B 75 and older. So we'll get to the educators probably in the next few weeks.
Okay. Yeah, a couple other questions here. Demographics in the trial is basically everyone over those age groups, 16 or 18. 18 is the Moderna and 16 for the Pfizer. Equal efficacy in all different age groups. They are studying it in children now. They'll probably get the same vaccine. And the allergy to the vaccine, no, they have not identified a specific antigen that caused the reaction. Some people are just, as you saw the list that Dan put out, there's all sorts of things in there. So, and not things that people normally get.
Thank you to you both. Really quick, I'm just going to go to Rebecca just so that we make sure we have a few moments with her before.
Okay.
And maybe one thing really quick, this question about 65 and older is going to haunt us because the Trump administration, and I'll just park my comment there about the Trump administration and how they've handled COVID. We can talk about that over beer sometime. But we're not ready to go to 65 and older yet. We, as I described, we're trying to fill up a lake with a garden hose right now. And so it's really important that when we've asked the state to support all of us at the local health level to not get too far out in front of our ability to put vaccine into arms. So although the feds are trying to push that everybody 65 and older demand and get vaccine right now, we just don't have the throughput anywhere in the nation to do that at this point in time.
Okay, thank you.
Sorry.
Go ahead, Rebecca.
Well, I'll just add a few things to what Dan has already said, because we are at hospitals we are still vaccinating. We started before the holidays. We are doing all our healthcare workers. And while we started with those, who were actually in the hospital setting, in our highest risk hospital settings, like the ICU and the emergency departments, we are actually moving out. And many of our hospitals, as you know, are part of health systems that have urgent care and primary care. And so we are really reaching into that entire spectrum and continuum to vaccinate. And because it is a two doses, we are continuing to do first and second doses simultaneously. And the vaccine is not mandatory. So we are expecting to continue to vaccinate as some people who may have declined early on will want to come back later and get vaccinated. So we do not see it as we don't see a finite end date, I guess, in our minds. And Dan talked about the many partnerships that hospitals are involved in. So I just want to thank the health department for that. We need to do it together to reach all of the the tiers that we're needing to get through. And we are building it as we go. And we were some of the first to start vaccinating. So we did learn a lot from just setting up our internal clinics that we are sharing with the county, and the county is sharing what they're learning as they're doing their vaccination sites and clinics. And I won't go, and we've learned a lot of lessons associated with, you know, getting throughput through those clinics, and that which is a challenge because of the fact that we do need to monitor for adverse reactions. It is an appointment. It is appointment based at this point because we are working through those tiers. And so it's not as easy as getting a flu shot. And I would love it to be that way, but I think we will get there in the next, you know, we're slowly inching towards that goal.
Yeah, one thing that I would add in this, you know, this just take us or leave it, but I've heard from a number of clinicians and physicians who are really concerned about sending folks 75 and older to these publicly run clinics for vaccine, who really strongly feel that older individuals who are at higher risks potentially for adverse reaction should be monitored by their clinician in their office. I'm not sure that I'm wise enough about the features of the vaccine and its reactivity in older persons. Russ might want to tackle that, but I'm just sharing this as it's part of the colorful debate that's going on in the background that complicates the whole vaccine administration strategy. There are folks on various sides of these debates, and all of us caught in the middle trying to figure out what's the right thing to do to really speed vaccine out there to the public, particularly those that are at much greater risk for serious illness, including death.
Yeah, and I think we're also trying to think through seniors who can't get out of their homes, who are in that 75 plus, or and then as we go down the tiers, and how would we reach people who can't get an appointment? So that's another conundrum we're working through as well.
Absolutely. Thank you all for joining us today. And I really appreciate especially our speakers being here. And again, the Opportunity Task Force leadership team for helping to organize this and bring it together. I'm sorry we didn't get to every question. If any of you are willing to put your email addresses in the chat so that people might be able to reach out to you, we always appreciate that. And we will be posting this recording for members. And if Russ and Dan say it's okay, I'd be happy to also share their slides. But more than anything, really appreciate you all being here today. This was incredibly informative. I know I learned a lot.
Well done.
Thank you all.
Thank you so much.
Thanks, everyone.